Hello, good afternoon, everyone. I'm Dr. Raj Narayana. I'm the principal investigator of IHOPE, and we are here to discuss about diabetic retinopathy in particular, but in general about how we can tackle the problem of diabetes, how to prevent the complications, and how we can improve the care of patients who have complications with diabetes. We have um, huge expert group today, stalwarts who have worked tirelessly on many aspects of healthcare. And I would like to start off with a brief presentation.
Yes,
Um, so today, the agenda is access to diabetes care. And on behalf of all the investigators of the Indian Health Outcomes Public Health and Economics Research Center, I would like to extend a warm welcome to you all for this meeting. Um, Incidentally, this year is the centennial year of the discovery of insulin. But unfortunately, at this time, we are seeing more and more patients developing diabetes, not just more patients, but younger patients who are developing diabetes. And there is extensive impact on the morbidity and mortality due to diabetes. We need to look at numerous ways of tackling this problem. I believe that a lot of work has been done, a lot of work is being done currently. There's no doubt about that, but we need to work together among all the stakeholders to be able to solve this problem using a common platform. And in that aspect, I think this meeting today, probably while looking at the challenges, hopefully would propose some solutions to develop a common way of sharing the knowledge that we are doing by way of research and activities, and also going forward how we can solve many of the issues of diabetes and its complications. I would give share some of my experience as the General Secretary of the Retina Society of India, all the retina doctors of India, because we see the most dreaded complications, the vision loss due to diabetes. And we have been doing, even before my tenure, a lot of activities have been undertaken by our society as well as other societies also, looking at various ways of spreading awareness, of increasing the skills at all levels from doctors to paramedical workers of screening diabetic retinopathy. But we all felt that nothing much was changing on the ground. In spite of increasing awareness, we knew patients who were aware of diabetes and its dreaded complications, but hardly bothered to convert it into practice in terms of either care at home or even coming for preventive eye checkups. These included doctors themselves who would never come for a preventive eye checkup. But then slowly we got together with the most important stakeholders where all patients converge, that is the general practitioners and diabetologists, through the Research Society for the Study of Diabetes in India, or RSSDI, and then also the Endocrine Society of India. We started working together, at least in spreading awareness about diabetes. We had joint radio campaigns. We also had workshops for training of diabetologists and ophthalmologists together. We had a joint certification course as well. And we ran these FM campaigns. We have been running it for the last at least 4 years in different cities across India on major channels in both English, Hindi, as well as local languages. I'll just play a brief
जिन
jingle.
लोगों को डायबिटीज है उनको सीरियस आई साइट लॉस भी हो सकता है। कहीं आप डायबिटिक तो नहीं? अगर हाँ तो आज ही अपनी नजदीकी आई डॉक्टर को विजिट करें। अधिक जानकारी के लिए विजिट करें www.savemyeyes.in। रेटिना सोसाइटी जिन लोगों को
So, while we did these and we tried to see if there was any change at the ground level in terms of more patients coming forward for preventive eye checkup. We know patients do come to us once they start losing their eyesight, but unfortunately it has been frustrating. And what I realized that ophthalmologists alone cannot prevent diabetic retinopathy. And then slowly I'm realizing that ophthalmologists, while we start working along with diabetologists and general physicians to maybe develop some guidelines, but it requires a much broader stakeholder approach beyond just ophthalmologists and diabetologists or a doctor only approach. We need to bring in all stakeholders together on a common platform. And that's why we are here today. If you have seen the agenda, we have a breadth of experts who have joined here today as either speakers or panelists, and hopefully we'll come up with some ideas for solutions. I'll just briefly introduce our speakers and panelists. I would like to thank Dr. Sudha Chandrasekhar for accepting to be part of this meeting. I would say at the last minute because the Deputy CEO of NHA could not come in, but we are delighted to have her here. She is the Executive Director, Health and Hospital Policy at the National Health Authority. She is a PhD from London School of Hygiene and Tropical Medicine, and I'm extremely happy to know that because we have a good connection in terms of both our co-investigators and expert advisory board of our IHOPE Center are from LSHTM. So I'm extremely happy to know that she's actually a medical doctor from Bangalore. So welcome, Dr. Sudha Chandrasekhar. We also have Dr. Sanjay Kalra, who is the president-elect, and we have worked together, at least shared common platforms on diabetic retinopathy and diabetes and related complications. So hopefully we'll be able to take it further from here. We have a great panel for the panel one, where we have Dr. Kim, who is the Chief Medical Officer at Arvind Eye Hospital in Madurai, and a very well-known ophthalmologist and retina expert in India, who will be coordinating a panel with Dr. Banshi Sabu, who is the President of RSSDI, Mr. K. Chandrasekhar, who is the founder and CEO of Forest Health, Dr. Nilesh Shah, who is the president and chief of science and innovation at Metropolis Healthcare, and also Dr. GVS Murthy, who is the co-investigator of IHOPE. In the second panel, our co-investigator of IHOPE, Professor Chirantan Chatterjee, who is at the University of Sussex, earlier at IIM Ahmedabad, will be having a panel conversation with Mr. Denny John again. He has accepted to be part of this panel at the last moment. And also Mr. Aris Rizvi, who is at Aon. Thank you again, both of you, for joining us. And in the last panel, my colleague from LV Prasad Eye Institute, Dr. Padmaja Kumari, who is also the head of teleophthalmology services of LV Prasad Eye Institute. She'll be in conversation with Dr. Claire Gilbert, who is a professor of international eye health at London School of Hygiene and Tropical Medicine, along with Mr. Tulsi Raj, who is the director of operations at Arvind Eye Care System. So with that introductions, I now request Dr. Sanjay Kalra. Thank you.
Good afternoon, everybody who is logged in. It's always a great pleasure meeting new friends, making new friends.
The screen share.
Yeah, making new friends and meeting old ones. And it is an even greater pleasure working under the tutelage of Dr. Raj Narayana. I think one of the main reasons why I like this is because I am able to come out of my silo, which is diabetes, and I'm able to meet with other stakeholders, learn from them, share experiences with them. There is a book by Stephen Johnson called Where Good Ideas Come From. And in that book, the author talks about some of the simple reasons which create new ideas. And one of the reasons that he identifies is cross-fertilization. When two different specialties meet, two different disciplines meet, 1 plus 1 doesn't remain 2. It actually becomes 11. There is even a law to explain that. It is called Kleber's law. But that would be a discussion for a separate day, a separate time. Kleber's law actually tells us then that when more and more of us get together, our neurons strike each other. It's not Brownian motion. It becomes motion in tandem with each other. It becomes a sensible kind of a rational kind of a motion. And our neurons are able to work with each other. They're able to connect to each other for the good, for the betterment of mankind. We'll talk today about diabetes. We'll talk about its complications. And we all know the figures, we all know the facts. This year, the new Diabetes Atlas has been released. 537 million people across the world live with diabetes. This is just adults, and it is going to rise in the future. Out of all these 537 million adults, 81% live in low income and middle income countries. Diabetes causes not only morbidity, but also mortality. And it causes a huge health expenditure. 10% of the global health expenditure is on diabetes. And this has increased threefold over the past few years. If we have 537 million adults living with diabetes, we have another 541 million adults living with impaired glucose tolerance. So this epidemic is not going to go away. You can hope that COVID will go away, but diabetes is endemic. Dysglycemia is endemic to our world now. And Southeast Asia, led by India, leads the charts. In Southeast Asia, we have 90 million persons living with diabetes. 1 out of 11 people in our part of the region, in our part of the world, have diabetes. Out of them, half are unfortunately still undiagnosed. All this complexity is made even more complex by the fact that diabetes itself is a very heterogeneous condition. Different etiologies, different clinical presentations, so different causations, different clinical presentations, different comorbid conditions, different types of concomitant therapy that are given to different patients. But what we do know is that all the downstream effects of hyperglycemia are the same, irrespective of what the etiology is. We can have acute complications of diabetes. So this is how we classify acute complications, which will include various syndromes of hypo and hyperglycemia. But when you look at the definition of diabetes and when you look at the cardinal symptoms, you will find that many of our books write blurring of vision. So that is actually a cardinal symptom of diabetes. So ocular dysfunction actually does become an acute complication for us. It is an acute complication of diabetes. It is also an acute complication of treatment of diabetes. Because when we give drugs which reduce the glucose suddenly, one of the commonest complaints that the patient will come back with is blurring of vision. This blurring of vision is usually because of change in visual acuity. But it can be an infection, it can be keratitis, it can be an acute glaucoma as well. So here there is need for the ophthalmologist to cross-connect with the endocrinologist or diabetologist. But why is there a hue and cry about diabetes? It's usually not because of the acute syndromes associated with the condition. It is usually because of the chronic complications. And in the eye, we have many chronic aspects of diabetes that are on view for us. We can have a cataract, we can have a glaucoma, and we can have diabetic retinopathy. It is retinopathy which enters our list of chronic complications. So first we spoke of acute complications of diabetes. How do we classify our chronic complications? Macrovascular, microvascular, and let me introduce a new term, viscerometabolic. We don't look only at the endothelium or the vascular bed. We look at each and every viscera, each and every organ system of the body when we are managing diabetes. It's just like a retina surgeon will, of course, he will or she will focus on the retina, but that doesn't mean that you will ignore what is happening in the aqueous humor or the vitreous humor or the lens or the iris. That is all the ophthalmology I know, by the way. No, I do know cornea as well. So I do know a couple of more parts. But the point is that you have to look at the body as a whole. Just like when you're looking at the retina, when you're managing the retina, you look at the entire eyeball. Now, all these chronic complications, you can have different permutations, combinations, but the easiest way is to remember three macrovascular complications: coronary artery disease, cerebrovascular disease, and peripheral artery disease. Along with these, three microvascular complications: retinopathy, neuropathy, and nephropathy. All these three go together most of the time. So we call it retino-renal association, retina and kidney together. But many times we have what is known as retino-renal dissociation. So the retina may be healthy, the kidney may be damaged. And this is a clue for us that we have to search for a non-diabetic cause of kidney disease. So it is the retina surgeon who will diagnose for us that we need to diagnose a cause of kidney disease. We are so dependent upon our colleagues who work in the field of retina. We spoke of macrovascular chronic complications, three of them. We use the power of three for microvascular complications. And let us move on to viscerometabolic, which I had introduced earlier. So if you have just a very simplistic way of understanding, if you have ectopic fat in the liver, that is non-alcoholic fatty liver disease. If you have ectopic fat in the retropharynx, that is obstructive sleep apnea. And if you have ectopic fat in the ovary, this is oversimplistic, but just a way of remembering, that is polycystic ovary syndrome. So hepatic, retropharyngeal, or ovarian with metabolic complications can be there. Let's move on to another power of three. And if you remember your embryology days in first prof, the nerves and the skin go together because both come from the ectoderm. So these three complications, dementia, diabetic dermopathy, and periodontitis, all three are gaining more and more traction. As our population ages, dementia is becoming a major problem. We now think not only of the nerves, but also of the brain. Diabetic dermopathy is quite common. We don't have good treatments for it. So that is why sometimes we don't bother about it. But actually the skin itself is a window to assessing metabolic health of our patient. And similarly, the oral cavity. The oral cavity is also a window which helps us understand the status of metabolic health. To add another list of three, let's look at mitogenic complications. So cancer and diabetes have joint risk factors. Obesity is one example of a joint risk factor. Smoking, substance abuse would be another example. Iatrogenic cancer. Theoretically, some of our glucose-lowering drugs can cause cancer. Theoretically, though we don't bother too much about that in practice. But still, this reminds us that whenever we are giving any iatrogenic intervention, any intervention in diabetes, we can cause iatrogenic disease. And when you use certain immunotherapeutic drugs for cancer, you can actually end up causing diabetes. So diabetes can be iatrogenic. It can be caused by the oncologist. So let's revise our complications all over again. Acute and chronic. In chronic, we have vascular, that is micro and macrovascular. We have viscerometabolic, which is the big three, the liver, the ovary, and the retropharynx. The new three, which is dementia, dermopathy, and periodontitis. And don't forget cancer or mitogenic. Now, what is the aim of sharing all these slides? In all these, there is a central role for the retina. If there is a role for the retina, then there is a role for the vitreoretinal surgeon as well. But what is the retina's role? Is the retina just a burden upon the healthcare system? This slide seems to say yes. The prevalence of diabetic retinopathy, vision-threatening diabetic retinopathy, and clinically significant macular edema is huge, and it is going to go up in the coming years. So the retina does seem to be a burden upon our healthcare system. Should we take pride in the fact or refuge in the fact that As Asians, we are less likely to have diabetic retinopathy as compared to Hispanics and Middle Easterners. Should we take refuge or be happy with the fact that our prevalence is less than that is seen in Africa or the North America and Caribbean? Or should we try to improve our own healthcare system and our own delivery of retinal care? If we continue looking at the retina as a burden, we will always remain depressed. But this is something I've learned from Dr. Raja and his colleagues. You can actually view the retina as a support system. Now, how is this possible? The retina, the retinal surgeon, can they support us? Yes, they can. As a metabolic physician, as an endocrinologist, I sometimes struggle just to assess the glycemic control and the metabolic status of my patient. I have so many matrices, so many different numbers, so many ways of assessing metabolic control. No single one of them is complete. But when my colleague in retina tells me about my colleague in retinal surgery tells me about what is going on in the retina, that is a very objective mirror to glycemic control. Extremely objective. Whatever report I get from Dr. Raja and his team, that is a mirror to the vascular health of my patient as well. I can trust the retina report more than the kidney reports. And also, when I get this report, it is a mirror to the status of self-care, self-management, self-motivation of the patient. When I see sequential reports from the same retinal surgeon, or even from different retinal surgeons about what is going on in the retina, I can understand how good my patient is at taking care of himself or herself, how much of motivation I need to bring onto the diabetes care table. So this is how the retina supports me in screening, in diagnosis, and in monitoring. In screening, diagnosing, and monitoring glucose control, vascular health, and psychosocial status of the patient. So, of course, the retina is a support system for me. But even more than that, when I look at retinovitreal surgery as a whole, I realize that the status of India's retinal health is a reflection of access to care. And that is our theme for this year's World Diabetes Day. Dr. Sudha will be speaking after me, and I'm sure she'll speak about access to care. She will also speak about objectivity, about quality. And this is actually what retina brings to the table. A retinal evaluation is extremely objective, and it is very amenable to quality assessment and quality management. So that is why the retina becomes a central focus for us in diabetes care, in endocrinology. The retina is integral to the system. And what I would like to request everybody is, now see, we've in the past 7 or 8 minutes, we've discussed almost the entire gamut of medicine. We've gone up to oncology. We've not left a single organ system. But the retina is integral to all of these. The issue is that just like I said, I remained within my silo. Our colleagues in retina are equally guilty. They also remain in their silo. So now that we've come out, why don't we begin speaking with everybody? Everybody associated with healthcare, whether they are policymakers, they are payers, whether it's the general public, whether you're speaking to peers, parents, partners, or progeny of people living with diabetes. If you're speaking to other physicians or even to paraprofessionals, why don't you spread the good word that if you want good quality, good objectivity, if you want a mirror into your patient's health, then believe in us, believe in the retinal surgeons of India. Because actually, you are integral to not only screening, diagnosis, and monitoring, but you are also integral to continuing care, and you are integral to outcomes. If our retinal care and the delivery of retinal care is optimized, automatically diabetes care will be optimized in our country. Thank you.
Thank you, Dr. Sanjay. We'll now move on to Dr. Sudha. I've got her slides, so just give me a moment. I'll project it.
Thank you so much, Dr. Sanjay, and thanks for prodding us also as retina surgeons and ophthalmologists to work closely with you. I can assure you that we will definitely work closely with your organization and take it further from here. I now request Dr. Sudha to give her talk, and Arnaz can move the slides from her side.
Yes.
Everyone, I think it has been interesting to know there's so much being done at your level at the clinical field. So here I would be actually sharing how we are able to provide that clinical care to millions of people in India through the Ayushman Bharat PMJY scheme. So the burden of disease is very clear. It is quite high, and we need to be very cognizant of the fact that that's an unmet demand that needs to be met through access to care. Next slide. It is not that it is just the retinopathy that is an issue, because as it progresses, we know the prevalence of further degenerating, life-threatening diabetic retinopathy is also very critical. So we have to be aware of this progression and ensure that we are able to treat the patients much earlier, right? So that is why it is important that we are able to recognize, provide access to early care. So it is not just providing access, but are we providing access to early care would also be important, looking at the kind of burden that we have. This graph definitely will show you exactly where the problem is, and I would follow this up with a graph where our facilities are. Right, so it's important that we know where the burden is across the country, but also see, do we have the access in a similar way across the country is also critical, because that is the gap that we need to assess and see where to build this additional capacity to manage and treat and provide care to our beneficiaries. For us, the outcomes is very important, because it is not just that we say that we can provide access to people, but also the kind of disability, the lost productivity is also important, because we are looking at the most marginalized group of people, and with this additional burden, they would be moved much lower down in their economic situation. So we need to ensure that at least the disability and the loss of vision to these people who are breadwinners in their families. So we need to be very clear that the productivity is maintained. Otherwise, they would go more deeper and deeper into the poverty. Under the PMJY, Ayushman Bharat PMJY scheme, we are, which has been in force since September 2018, and which is termed as the largest health assurance scheme in the world, since it covers up to 5 lakh per year per family with no cap or family size, age or gender, which is like many of the various earlier schemes which had some limitations has been overcome, and providing care to nearly 65 crore citizens, right? Both a combined state and a central scheme has been able to expand the scope of services, covering secondary and tertiary care, hospitalizations, and pre-existing condition. And one of the unique features is also that portability. So it doesn't matter where you are in our country, you will have access to care across the country with this common PMJY eligibility criteria. And it's completely paperless and cashless. So it is important that our hospitals are very much aware of these and check for availability from the beneficiaries and ensure they are able to provide the care. Again, 33 states we are implementing. There are still 4 states who are yet not part of our program. We have around 24,000 hospitals empaneled, with more than 50% of public hospitals also in the scheme. We have distributed around 16.5 crores of the Ayushman card. So that gives an entitlement, because people feel much more stronger and empowered when they have a card to share eligibility, and they can walk into any of these empaneled hospitals much more confidently than looking at whether they would be identified, would be covered. So that is one of the major drive that we are doing. And as of now, we have already reached 2.2 crore admissions and spent around 24,000 crores. And we have a good interactive platform with the beneficiaries through the call center, and it is accessed around by 76 lakh calls that has been answered. This is general overview to see the mammoth scheme that we are talking about. And as we move ahead, we do look at what is the kind of uptake. So when we look at the network strength for the PMJY for ophthalmology, you can easily see that, there are a lot of public hospitals empaneled, and across the states, there are different level of, capacity and participation. So when we look at the private hospitals, again, they are, especially in the high-end ophthalmology care, private hospitals are also very important. So we do have a huge representation from the UP, whereas it's, very graded from many of the other states. And some of the states like Delhi, Odisha, Telangana are not part of the, West Bengal are not part of the scheme. So, but we still have some ministry hospitals and direct empanelment of a couple of hospitals in those states. And specific to diabetic retinopathy, we do have these packages, which, for laser photocoagulation and VRS surgery. So these are available, and they have been utilized. And the uptake, as we know, is still needs a lot of, which needs to be taken up much more. But this is with the latest revisions, and package pricing are a continuous process of evaluation. So we have moved from our earlier HPP 1 package list to a HPP 2 package list with additional revisions, and it's a continuous process of evaluation of the appropriate pricing strategies. Further, to ensure the quality of care, we have also customized the standard treatment guidelines under the PMJY. So we have worked with the clinical experts who have developed these and also referred to the available guidelines from various professional associations and customized these to our requirement, which aids in processing of our pre-authorization and claims. So, and adherence to these guidelines, so that we can check some compliance measures, as well as look at care is being provided to some.
I think we have lost your audio. Is that right, Arna? Are you able to hear her?
No. Okay. Dr. Sudha, we lost you.
Can you not hear me?
Now we can.
Hello?
Yes, we can now. We lost you in between.
Maybe you can turn off your video, Dr. Sudha.
Can you hear me now?
Yes.
Okay.
Should I move to the next slide? Dr. Sudha? I think she's dropped off.
Is it better now?
Yes. Should I move to the next slide now?
Okay. Yeah, you can move ahead. Mainly, we have tried to ease the processing of pre-auth and claims for the teams, because when these kind of claims come into the submitted by the hospitals, it's important that it's appropriately processed so that there is a timely payment of these claims. So we have identified the required documentations and specific review mechanisms to ensure that they are appropriately followed. And these have been integrated within the IT system, so that pop-up comes in, so that, specifically the hospitals and the processing team can actually check for these things while they are approving the claims. So overall, we have seen that around 9,000 plus pre-auths have been raised. And it's interesting to see, especially for all these kind of procedures, majority, 92% has been from the private sector. And male-female ratio, again, we see there is some difference, major difference actually, from the female contributing much lesser percentage. And around 15 crore rupees have been supported for these conditions as a payout to the hospital. So in that sense, we do understand that the capacity at the public hospital to handle these high-end retinal procedures is quite limited. And that is an area that needs to be augmented to ensure more equitable care across the country. So when we, package-wise, if you see, I think BRS surgeries are the main key procedure that are being performed. Followed, that also means that it's a much advanced level of retinopathy, right? So it is the early kind of treatment packages are much more, less utilized compared to the advanced packages. So we need to make sure that the patients are brought to care at a much earlier stage than actually going in for complications. So as we see, we saw the distribution of the hospitals, but if you look at the state-wise kind of distribution, we do see there are patchy hotspots within our own within different states, and we need to be clear that whether is it because of availability of certain services, or is it because the patients are more in these states. Because as we know that Kerala, every district hospital in terms of, has a good eye care facilities, even at the public hospital. Whereas if you look at many of the other states, they might not be that much availability in the public sector. Whereas if you see that, very specifically, some states are having more patients compared to other. Whether this matches with the current exact burden of the disease needs to be looked at and identify the reason for these gaps, why some certain states have been able to provide these services. So as we move forward, we do realize that we have to work collaboratively with various arms of our own Ayushman Bharat, which is the Health and Wellness Center, and also linkage with the national programs, blindness control programs, and other specific programs which can help in early identification and screening for diabetic patients, including the NCD program. And we need to build in the capacity of the grassroots level workers also, and see if technology can help because there are many newer technologies that are coming in wherein they can actually scan, and through telemedicine the reports could be read. So we need to ensure that whether such could be scaled up. There are some isolated experiences. We need to ensure that needs to be scaled up. And public hospital strengthening is also very critical for us, and we do look forward to identifying this as one of the specific requirement, and see if our Ayushman Bharat infrastructure mission can address these, and would push for certain specific resources for upgrading the ophthalmology facilities in the public sector. And as we said, leveraging AI/ML is very important, because that could really help in early screening and more appropriate diagnosis of many conditions. So thank you, and sorry for the technical glitches.
Thank you so much, Dr. Sudha. That was wonderful. That was enlightening for all of us. In fact, I am pretty sure that every person who is attending here would have on every slide of yours quite a few questions. And already many questions have been posted, but I don't think we have enough time to take questions from all of the attendees here. I would probably suggest that we can pass on some of the questions in the chat box to you if you can respond later on. But I have one question, Dr. Sudha. In the last slide, which you mentioned about the various aspects in which Ayushman Bharat and PMJ can benefit, at least from the diabetic retinopathy perspective, I was wondering if there is any help required from this group of people who are attending today in any way, because
इसका
if
कुछ
a lot
बताया
of people here are experts in different areas,
मैंने
including
कहा
AI
अभी
and
कुछ उसका
ML,
अपडेट थी उन्होंने
or even skill shifting. There are numerous people who have worked in these areas here, but would be happy to contribute in some way. But is there any system that you have at NHA where we can contribute to this, at least from the diabetic retinopathy perspective?
Yes, especially the medical experts. We do have a medical audit, medical cell, expert cell at NHA, wherein that is more advisory and that gives us more update on the latest advances and helps us to develop the health benefit packages, what is missing, what needs to be expanded in terms of the scope of services. And also we are very happy to be already associated with you for trying to develop some guidelines specific to certain ophthalmology conditions. So those are areas that definitely we look forward to, and also the newer technology. So we would like to see if there is maybe anything that could be adopted at the hospital level, at the screening level, as in when these are able to be scaled up, we could introduce that as a part for reimbursement for the beneficiaries. So maybe updating our teams at the national level is also very critical, because you're regularly in the field and managing patients. So any kind of additional inputs on the changes in the guidelines, changes in the treatment modalities would help us to keep up to date with the changing treatment protocols.
Thank you, Dr. Sudha. I think we would be happy to send you a write-up on all the aspects which we have covered from our expert group sitting here today, including the aspects of health economics, the reimbursements, and some treatments which are probably not covered but very often used in the management of diabetic retinopathy. But please do let us know if it would be valuable. If we are very keen to contribute to this cause through the NHA, and we would be happy to send you a written document on all these aspects. Thank you very much.
Yeah, just one question I thought I would answer so that it clears a little bit on the data issues. We do have because some of the states are not part of PMJY, we don't have the claims information from those states. And secondly, some of what I call the brownfield states maintain their own IT system, wherein the IT integration is still under process, wherein it doesn't completely integrate for us to take the data, updated data that is available. So that is why we have limited the data requirements, what is available, most updated from the level of states that are possible. So that is the only limitation I find.
Dr. Raja, can I ask a quick question to Dr. Sudha?
We are actually.
Dr. Raja, can I ask a quick question as a follow-up?
Yeah, you can be brief, Chiran.
Very brief,
and
yeah.
then
So
Arnab will take over after that. Yeah.
If 1 in 5 Indians are suffering from diabetes, this means from 1.3 billion people, a certain number are suffering. How many are not getting catched because the IT systems are not harmonized and some states haven't enrolled? Do you have an estimate of that number because of diabetes prevalence? Because the brownfield states that don't have IT systems harmonized, or Punjab and West Bengal like states haven't enrolled?
Not all 1 in 5 would be eligible under the scheme also, right? So
there would so the base changes.
Cover the base itself changes. So we are only covering around 500 million individuals. So definitely it will change. We don't capture all the beneficiaries who are taking services. So, and even if you're eligible, many people may not have been aware of taking the free services. So that is also a limitation, that some beneficiaries may end up still having an out-of-pocket expenditure, which are not covered under the scheme. So that
How
is
many
one.
are we missing out of those 500 million because of these frictions? Any sense, any estimate in our study on that?
We are not yet aware of any, we have not done anything specifically for diabetic retinopathy as such, but we do know that, we do miss some of them that is one of the reasons that 16.5 crore cards have been distributed. So definitely they are aware and eligible, but that's a process. We need to reach to 50 crore families. So that again means nearly 50% they have not received the cards. So it's a work in progress, that the entitlement eligibility, though it is expressed in the scheme, it will take time for everyone to be fully aware and also have these kind of cards which can give them more awareness and entitlement.
Thank you.
Thank you, Dr. Sudha. We'll now move ahead, and I would like to invite Dr. Kim to start with the panel discussion on how do we improve screening and diagnosis of diabetic retinopathy. We have Dr. Nilesh and we have we have Mr. Chandrasekhar and Dr. JVS Murthy here. I'm not very sure if we have Dr. Banchi. I think he's just joining us, so maybe we can start off. Thank you.
Thank you, Arnaz, and thank you, Raja, for this initiative. And this is one topic, that is screening and diagnosis of diabetic retinopathy, is very hard for various reasons. It's there, and people are, I mean, most of the people are getting aware globally on the need for doing this. And almost every ophthalmologist is getting into this. So we will see a huge change happening in the time, but we need to systematically introduce a lot of process in place for this to happen. So just to start with, I'll start my first question to Nilesh, as he has to leave for another appointment. Nilesh, what steps can be taken to improve awareness about diabetic complications and also opportunistically screen these diabetic patients through these diagnostic labs?
Good afternoon, everyone, and thank you again for inviting me for this wonderful discussion. I have been running labs across India and dealing with a lot of diabetic patients. Screening patients, diabetic patients for diabetes retinopathy has been a new subject for us about 6-7 years back. And I want to share one small pilot which we did. It will be very useful for this forum, I believe. So we had aligned with Zeiss, who had a handheld device for diabetic retinopathy screening. And they geared us up for doing that screening program for our non-diabetic patients who have been very regularly coming to us. And we agreed for a pilot at our Bangalore lab. So at Bangalore, we have a huge walk-in base, and we have been dealing with a lot of diabetic patients, and they have been coming for years together at the same place. So we did one pilot, and the pilot to some extent was not too successful for us to go ahead further. And the issue is not the device, issue is not the concept, but probably the way it was conceived, executed, and we geared up the team had some improvement required. So I just want to share 2-3 important points which happened there. So one of the key points which patient said, that once we have done the test, ultimately report is going to go to ophthalmologist, and anyway ophthalmologist is going to screen me again. So why should I do the test at your place? So this was one point which came up. The second point, we felt that our own internal, I think planning, execution, training to front-end staff and all also needed improvement. It was not well done. I want to make some recommendation and suggestion. I definitely agree that we as a lab, and many of the labs deal with a lot of patients, and that's a right place where we can do a screening. But there are few things we need to be taken care of. Number one, the concept selling, that awareness about this kind of a devices which come, handheld device or any other tool which may come up in future to come, the good awareness has to happen with diabetologists and ophthalmologists. Otherwise, these reports, when they come from the lab, they are not very uh, well accepted. But if there is an awareness created and if there are success stories around which are shared with them, I think it will get well accepted, and hence things will move better. Second thing, from my front end, a lot of training need to be done. Like a phlebotomist talking to a patient and saying, "I've got one more tool which will screen your retinopathy." I don't think patient would love to hear any additional test recommendation from them. So there has to be a different way of doing, where probably you can put up patient education flyers. You can probably have some online doctor counselor available for the patient and so on. Very simplest thing one can do is creating some packages where when you are doing a diabetic screening, I'm not recommending too much of wellness packages where you put this uh, retinopathy screening, because when you do wellness screening, maybe 1 or 2% people may turn up diabetic, not all. And for non-diabetic people to push them for this test may not be appropriate. So at least your diabetic packages which are there, and for walk-in patient, you can include retinopathy screening. Moreover, one more thing which was a feedback which we must fix, that these reports being signed by an ophthalmologist brings better value and credibility than a pathologist or physician signing. So if these few things are taken care of, I think it's a fantastic thing to do, very useful for diabetic patients, and I think it is overall good for patient care. This is my small experience which I wanted to share with you. Thank you so much.
Thank you, Dr. Nilesh. I think you really brought out a few very important points in this process. We have been doing this for the last 20 years with some of the labs, even medical shops, because these are the first point of contact for the diabetic patients. They may not go to the diabetologist, but they go to these labs to regularly check their blood sugars, whatever. So we have been trying to project it as a one more investigation, just like they do the blood investigation. We've been asking these people to do, and that's kind of somehow keeps pushing, at least to a certain extent, a few of the labs to do it. So I think this is something we have to pursue, because it has got a huge potential in capturing these patients early on. You're right on the fact that it needs to be packaged in the proper way, and the training is very, very important. Thank you, Dr. Nilesh.
My pleasure.
Any points, Dr. Murthy, you want to add on this, Casey? This, God?
If I can add, I fully agree with. So we have tried many models for the last 5 years. In fact, Dr. Kim knows this. We tried with Arvind Madurai. Dr. GBS has also been supporting. We have tried many models. What I honestly believe, and I'm not saying we have cracked it, but what I believe is when you do a standalone diabetic retinopathy model, I found it not working out from a revenue standpoint or from an ROI standpoint. The moment we started integrating that with spectacles, when we say comprehensive eye examination, we find that there is a decent ROI. And because our intention is actually to go and do diabetic retinopathy screening for most of the diabetic patients, if we keep the price point low and then kind of bridge with, giving spectacles and kind of manage that, and kind of widen the net. So we started doing corporate screening, touch points where there is the ability to pay, doing in manufacturing, doing in chemist shops, doing in home screening, and then of course the diabetology. So I think the bridging model, what kind of seems to be working, I'm not saying that we've kind of cracked it, but seems to be comparatively working than a standalone diabetic retinopathy model.
Thank you. Yeah, since there's a lack of time, I'll move to the next, to Dr. Murthy. PHFI has been doing some excellent work in this field of diabetes and diabetic retinopathy. We've been taking a lot of initiatives, academic, clinical, in the service delivery, quite a lot. What are these initiatives that has been done for DR diagnosis, and what lessons have we learned? Because I know for quite a few things, there have been quite a few challenges that we have faced when we worked along with you in PHFI. So would like to hear from you, what are the lessons that you have learned from these different approaches in diabetic retinopathy screening and identification?
Thanks, Kim. I hope you said challenges which we've had to face together, and I hope it was not challenges with PHFI, because what you said sounded quite loaded. I'm just joking. Right. So yes, in terms of the work that PHFI has done, I would put that into two baskets. One is in relation to diabetes, and a lot of work has been done in looking at mHealth initiatives in 6 districts across the country in relation to diabetes management, using the NCD clinics in these 6 districts. That has been something which has been going on. In Visakhapatnam, there has been a long cohort which has been followed up in relation to the incidence of new cases of diabetes. So that is in relation to diabetes. In relation to diabetic retinopathy, there was a grant from the Queen Elizabeth Diamond Jubilee Trust, where we worked with so many of you across the country. Of course, Claire is there today on the call too, with you, Kim, with Tulsi, with Casey, and Padmaja, and a lot of teams. So we were working across 10 districts, and there it was, in terms of the objectives, we had 3 basic objectives when we looked at this particular initiative. And this was that most of the people in the rural part of the country, at one time, we felt that the prevalence of diabetes in the rural areas was lower. And as time goes by, we now know that the differential is very small. Now, looking at the rural areas, in terms of the formal system, excepting the primary health center, the community health center, on the government public health system, you do not have any other facility. We also looked at reaching out to women who are diabetic and who may not get services if they do not go to a government facility, the marginalized who may not be able to travel far, and therefore investing in building partnership with the public health system was the main objective, so that the marginalized groups could be taken into care. The third aspect in looking at a public health system was that when you're looking at diabetic retinopathy screening, you want to piggyback on a facility which is providing the medication, treatment, and routine investigation for diabetes. And that was the NCD clinics which was set up. So that was at the community health center level as the entry point where we could piggyback the diabetic retinopathy screening. So that was the intention. And as Dr. Kalra mentioned, on the other hand, we had 3 collateral benefits that we were looking at. One is the integration of the diabetes or the non-communicable disease program with the National Program for Control of Blindness, because though you look at the eye, you don't see eye to eye with each other. So that was one reason to look at that. The second level was the ophthalmologist and physician. How can we bring them onto the same plane? And you, Kim, have been instrumental in developing the program for the medical officers across the country who could be oriented to the complications in diabetes. Again, something important to bring those two together. And thirdly, to bring together the excellence in the NGO sector, eye care sector in India, to help the government by handholding and developing these facilities. So across 10 states, we were able to look at different models, mobile versus static, incentivizing an ASHA, does it make a difference? Incentivizing the A&M, does it make a difference? The NCD clinic nurse, which you used in Tamil Nadu, the paramedical ophthalmic offices in other states. What we found is an ophthalmology-led service would not be able to sustain itself. An ophthalmologist can support, but a led program, unless you're providing treatment, at least a laser in the field itself, so that people, you go to the CHC, travel there, you go with your laser machine, treat them there, yes, that is an opportunity. But otherwise, the sustainability of an ophthalmologist-led program in rural India did not seem very attractive. You look at the rural area with a 10% prevalence, you're looking at about 130,000 people with diabetes, 50% detection rate, 65,000. Out of those 65,000 in the rural area, at least half will go to the government health system. So if you're able to tackle them, you're making an excellent start. And that was the intention. We would have loved a much longer period of intervention, but we could, because of the challenges that you may mention, getting the governments to agree and then rolling it out, we ultimately could only have about 2 years at the most of implementation, where we were able to get about 66,000 people with diabetes screened and about 8,000 people who needed treatment. 50% of them could be treated. We were able to strengthen 16 non-communicable disease clinics in the CHCs and the district hospitals, train a large number of ophthalmologists, ophthalmic officers, as well as medical officers. So if you look at it on a holistic sense, this was a very good beginning. Some of the states, like the work that you do in Tamil Nadu, there is a continuity. In some states, there was no continuity. COVID worsened the situation because most of the elective facilities came to a standstill. So you need to look at advocating with the government to see that there is a continuous activity without a break, so that people in the rural areas, especially the women, the underprivileged, and those who cannot afford it, do not lose the benefit of having a screen for diabetic retinopathy. Excellent lessons for us, and it all depends on how we actually implement the learnings in the future. That's from me, Kim.
Thank you, sir. I think that's a tremendous work that was done by PHFI. And I'm sure, all these lessons that we have learned from this will be a great use in implementing across the country, especially for the rural India, where we are still seeing the lack of, access for care, as you mentioned, for these people to have any treatment is still a challenge. I think we have to still, extrapolate what we have learned across the country. So thank you for sharing that. And
my pleasure.
Thank you. I'd like to move to Casey. Thank you, Casey, for joining us. I know you're on the other side of the world. It must be 3 o'clock or 4 o'clock early in the morning. So you've been doing a lot of work. You're one person who brought in this much needed low-cost fundus camera. And today it's making a big impact almost everywhere. So, and you've been also, establishing screening models. You established some of the business models for screening, and then you've also implemented screening models not only in India, in many other countries. You've started working on it. I'd like to know how it has been working, or what are the challenges that you've been facing in this, or how business model innovations can help reach more people who need this access to care.
Thank you, sir. It's really a pleasure to be with you and Dr. GVS, two of my mentors in this space. I just remember only one thing. When I met Dr. Namperamal Swami almost 10 years back, he said that the only way to solve this problem is that every physician, every pharmacy should start screening rather than stopping at an ophthalmologist level. So we have been working on this right from day one, and one is actually making the product. Once the product got accepted, one of the clear things which came was that when you have to deploy it in non-ophthalmology setups, it cannot be on a selling the product, the capital equipment model. So you have to innovate on business models which are completely subscription based. Now, while it's very easy to say that subscription model works, because there is no capital investment by the end consumer, which is, let's say, a diabetic center or a GP or a diagnostic center, there was no skin in the game for them. So initially we tried a lot of these models and actually must have failed in at least 25 or 30 models, which we tried working it out, and it never went further. So there were, if at all it succeeded, it was succeeded because the person on the other side was more serious rather than the model itself was successful. So we had to make a system where it is not a very person dependent, even though the person dependent something actually accelerates the process, but we had to create a system where it will run on its own. It is a scalable model, not just it works in isolation, just say in Tamil Nadu or in Kerala or in Karnataka. So we have been working on a model where we have to create a product, then we have to create a platform. So when we create a platform, we become device agnostic. So even if there were other devices which were already existing, we connect to the platform and the platform connects to multiple ophthalmologists. And as Dr. GVS was always saying that connecting to the treatment ecosystem became very critical. So we had to connect at two levels. One is virtual. So we have an application which connects the doctor and the patient the moment he's diagnosed with a problem in a report. And Mr. Nilesh also said that, the patient wants to get a report from an ophthalmologist. So when you get a report signed by an ophthalmologist, that gives them a lot of, towards that this is a valid report. And our aim is not just to screen, our aim is to ensure that the patient goes for treatment. So that being the case, the next step is also that how do you also take care of chronic patients who have been identified with the problem, ensure that they continuously are on the screening radar, they don't go out of the radar. So we're trying to create something on the disease management side along with the ophthalmologist so that they go. So there have been lots and lots of learnings, but I think the biggest important thing is actually making the entry barrier low by making it into subscription and also making that a viable model for somebody like us also, because you work for some time and then after 2 months it moves out, then it's not a sustainable model. So we need to kind of create that. And I think we are there. I won't say we have cracked it 100%, but we are there. I think with few more modifications, I think we can build a model which will scale across the country.
The advent of AI, do you think things are going to change? Because, completely rules out an ophthalmologist position today. Many people are using AI for in real time on screening. Do you think that will make a big change in the way we are doing this?
Sir, I think there are going to be two things. Sir. One is a lot of people believe AI is going to change, so they will accept. Second is a lot of people still don't believe that it is matured enough. So I think the option should be left to the end consumer or the end service provider rather than we dictating. So our system should be as flexible as possible. So we created our own AI, and our AI is not autonomous. We designed it just to ophthalmologist assist. But you also have, that we integrated with Google, which is an autonomous setup. So this may work in a setup where the service provider, which I'm talking about, a diabetologist or a GP, feels that his patients are going to be very happy with getting an instantaneous report. So you should have that flexibility. And there are service providers who feel that report, like just Dr. Nilesh mentioned, that they're more happy with an ophthalmologist signed report. So I think the system has to kind of mature, give the flexibility. And after, let's say, 2 years, we will be able to provide data within that own setup. Because if you say that AI worked in A place, B place, they'll still isolate it as a separate one. But if we say that, in this company, we screened 10,000 people, AI was in the background, the doctor graded X, and then the sensitivity is 99 or 99 or 100%, then the tendency to buy it 100% is going to work. And that also I feel is going to be in two phases. So instead of sending every image to an ophthalmologist, you will then say that when the AI graded it as no threat, you don't send those images, but send only images which were saying that it's abnormal. So I think it has to go in stages and also depend on the service provider.
Thank you, Casey. Yeah, I know this is evolving, but since there's a lack of time, I would like to ask one more very important question about the role of general physicians in screening. But since Dr. Banshi, is Dr. Banshi here?
No, he's
No,
not.
no, he's not.
Okay.
Yeah.
I know, sorry, Raja, I know we are running late, so I'll stop here so that because we have 2 more panels to go.
Yeah.
We can probably derive.
Thank you so much, Dr. Kim. Yeah. Thank you so much. Very unfortunate we are running behind time. Over to you, Arnaz.
Thank you, sir.
Yeah. Thank you all. I would now like to request Professor Chiranthan Chatterjee to take on the next session, which is about how do we address affordability.
Right. Thank you very much, Arnaz. So maybe I can request our 2 panelists to come up with their initial thoughts, and I have a few follow-up questions, and we can open up for some Q&A. We'll try to keep it short as well to make sure that the time is not mismanaged. Who wants to go first?
Well, Professor Chatterjee, I could go first. And
please go ahead.
First of all, thank you so much, Dr. Raja, for arranging this session. I think it's always a pleasure interacting with you and your colleagues in the field. And I've been listening very intently to, a lot of information, which is a learning for me as well. And I did go through some of the questions that Arnaz was kind enough to share before the session. I think there is a lot that is happening in terms of improving access, to the bottom of the pyramid from all quarters. I think the government is doing its bit. I think the private sector is doing its bit. But I still believe that there is some work that needs to be done in terms of better coordination. That's one. I noticed that there was a question around what best practices that are there that could be looked at from around the world and see if they have any place for implementation in India. I feel, with my experience, that India is a very unique country, and as you mentioned in your chat as well, a nation within nations. Right? There are nations within nation. The challenges are very diverse, and I believe if there is any meaningful idea that needs to be implemented to improve access and affordability, I think that needs to come from within our social milieu and our context itself. And I think that the work that we are doing needs to be done with a lot more vigor. I think there is a lot more that can be done to leverage areas like social media to improve education and awareness. We continue to see health mismatch, health access to health, a mismatch there, not just on an economic perspective, but also gender. I think Dr. Sudha's slide did mention the low uptake of women for screening programs, etc. So I think there's a lot more work that needs to be done there. But these are just my sort of opening thoughts, just to get the session warmed up.
Okay, can we have the contribution from our other panelists, please? Mr. Denny John.
Not able to hear him.
Denny, you have to unmute yourself, I think.
No, I think he's unmuted.
Oh, you have a device issue. In which case, maybe I can take my questions up, and Denny, we can come back to your take on the questions and also your overall thoughts, all consolidated, just to save time.
Yeah, but basically, you're not audible. I think you need to work on your device issue. Yeah, go ahead, Chirantan.
Basically, of course, I worry about precise estimates as my interventions on the chat window indicates. The problem with estimating and hence screening as a result, catching diabetes early, therefore healthcare planning probably lies in the fact that harmonization and careful understanding of frictions and outcomes uh, is still a work in progress, I would say, in our country's context. And yet it is the diabetes capital of the world. So the question is what we as a community, as an ecosystem do here to build more evidence on that. And in that context, I would love all of us to look at international best practices. So while we keep saying that India is the diabetes capital of the world, there must be some examples of good best practices globally where countries are doing a better job of managing diabetes and some are not doing good jobs where you can learn from failure. So I would love both of the panelists take on any awareness on this issue of how we can benchmark government guidelines and diabetes prevention and management with best practices and failures in doing screening as well as catching, reducing the prevalence. That's one question I had. The second one I had for them as well as our esteemed participant from NHA and others is basically on how should one think about setting the optimal reimbursement rates for low cost scanners, and what might it do to quality of care as a result. I do work on the pharmaceuticals context. We know that there is a large debate on relaxing patents on oral anti-diabetic drugs like DPP-4 inhibitors. And at the same time, there is a conversation as well on the quality of these metformin gliptin combinations in the market. Myself, I'm recently detected to be diabetes, so I'm learning this more beyond being a pharma economist. So I would love your take on how, as you settle the optimal reimbursement rate for enhancing access, you are thinking about not dropping the ball on the quality of care, whether it's on screening or on drugs, etc. The third thing, as I have already highlighted, is the thoughts on harmonizing guidelines between participating states, non-integrated states like brownfield states, etc. And lastly, how much evidence is being generated on the extra burden on diabetes coming out of the pandemic, whether it's through excess steroid consumption or sedentary lifestyles. I would love to know what's out there in terms of evidence there. So yeah, over back to the panelists. Then you can take over, either answer my questions and then those thoughts, or your thoughts and then the response to these questions. And I would love our other panelists and open up for a general reaction here.
Am I audible now?
Yes, please go ahead.
Oh, okay. Thank you. Sorry for that goof up. I think there was some error. I think so having worked in LV Prasad almost a decade back and then moving towards evidence-based medicine, mostly doing systematic reviews and economic modeling, I think we need to look at affordability from various angles. Now, I'm just going to pick up certain points which might be considered because I also worked in public health from a health system point of view. So I'm not just going to take on the input side, but also, for example, one of the things that we did way back in 2018 was to understand what was the factors that influenced adherence to glaucoma medication. And we found that cost was not the main reason. It was actually forgetfulness. And I think adherence, medication adherence should be one factor that need to be considered where affordability is concerned. However, I think it also matters on ensuring that there are other non-financial aspects that could reduce the overall, it could improve the adherence as well. From the affordability side, we all know that insurance penetration is improving, but it's only mainly due to the penetration of the government health insurance program and not actually the penetration in terms of how the private insurance is moving ahead. However, in ophthalmology areas or disease specific to ophthalmology, it's still hospital based. It still doesn't cover a lot of outpatient care or a lot of medical, the coverage for medications or reimbursement from there is quite limited. I think the affordability has to look from a demand side perspective as well. I think we need to move, we need to bridge somewhere the supply side and the demand side, aspects, financing aspects to have some balance in which those reimbursement mechanisms can work out.
On the questions related to my 4 things that I'm worried about in diabetes guidelines, how do you think we can think about optimal reimbursement rates? What are the international best practice benchmarking happening? How can we harmonize the guidelines across different states? And um, what's your take on the short run effect of the pandemic on diabetes prevalence?
Right. So I think I'm chair with the Cochrane Economic Methods Group. And something that we do not notice in India is how can cost, in fact, we did how are costs being captured in the clinical guidelines. We actually did not in ophthalmology, but a couple of years back, we tried to assess in obstetric and gynecology guidelines in India, whether cost was being considered within the guidelines itself. And we found from 26 guidelines, clinical guidelines, none of them looked at cost as part of the consideration for the guideline development. I think that is where probably looking at cost and cost effectiveness while associations and government prepare clinical guidelines and treatment guidelines for ophthalmology, they need to consider the cost of not just the treatment, but the entire care pathway. And I think that is where probably one of the ways in which you can integrate it. And I'm sure there are nice guidelines that can be at least the method for integrating cost within care pathways is possible. How we do it would be a challenge. For example, many years back when I was part of LV Prasad Institute as part of the management team, and I used to have a lot of challenges to ensure how do we get, because I was in charge of the insurance patients there, it was very difficult to explain the lot of the costing part that was done to insurance companies at that particular time. The main reason was because we used to follow certain pathways of care across the departments, but they never cared about it. They still followed the lowest cost possible kind of logic. I think the insurance companies will also have to wake up to the whole clue of that there is advantage of following standard practices and guidelines. And probably they could also integrate the cost calculations when they link it up to insurance reimbursement in that area. I think we all know money follows the patient, but I think in this country, we also know that the insurance also drives some of these requirements. And I don't think the insurance companies are talking that language that we are all talking.
Tulsi has a question.
Yeah. I just wanted to kind of broaden this conversation around affordability, because if you take this animal diabetic retinopathy, amongst the diagnosed diabetics, I think if my math is right, possibly 1 in 10 or 1 in 12 may be the one who will be actually requiring active intervention. For the vast majority, the cost is around accessing care. It is not around the cost of care. So there is no reimbursement that applies to them. No, so I think we also need to keep in mind when we talk affordability, how do we reduce the cost of accessing care? Because for every patient who gets intervention, 10 don't get intervention. But they have to be monitored, wherein the doctor would say everything is fine or whatever. No, so I just wanted to broaden the conversation. Yeah.
Okay. Anyone else? Aris, do you want to respond to the points I raised, your thoughts, and also anyone else wants to raise their hand and broaden the conversation?
Yeah, actually, yes. Sometimes we also tend to sort of oversimplify the problem and say that perhaps, there are 1 or 2 things that if done right could solve the problem for good. But unfortunate reality is that rarely happens. And insurance is one such animal. And I come from an insurance background, and, that's the expertise I speak about here. Look, India still has a problem of insurance penetration, and we all know about that. Right. And there are multiple reasons for that, but one of the reasons is also affordability. At the end of the day, a 7 to 8 to 10,000 rupees as an insurance premium is still quite high for a large segment of people who would not be able to afford treatment, right? And the more you start, for example, enrolling members who are at high risk, and therefore the insurance outcomes go higher, the treatment costs go up, and therefore the premiums rise as well. And so if you really look at, where our insurance premiums are compared to the Western world, it's a fraction of what premiums, we charge for health insurance policies compared to, what are charged in the US or in Europe. A large part of Europe is anyways has universal medication, universal health. So I think we need to find a more suitable perhaps solution for India. And I sort of agree with, Dr. Tulsi. He did mention that a lot of challenge around the costing is not just the cost of treatment, but also how does a patient sort of, reach to the specialist? What are the challenges that are there that need to be solved? I want to really talk about how telemedicine, and a lot of work I think Dr. Kim would know already that has been done by his organization, right, to leverage telemedicine to improve access and really lower the cost of treatment to people, and also improve the overall screening. The other area that we need to look at is how we can engage more and more private players who have stakeholders who are stakeholders and who have skin in the game. For example, corporations. I think we as an organization go out and are sensitizing various organizations about the need to screen more and more employees. So far, like it has been mentioned earlier, that most of the insurance programs are largely concentrated on an inpatient narrative and paradigm. A lot of now corporations are looking at covering various treatments that could be done on an OPD basis as well. Whether it's MAP treatments, anti-VEGF treatments, etc. So I think there is an increasing awareness in the insurance sector as well that is evolving with the needs of the customers.
Are there other questions that people want to ask? I especially want to know, how can we fix on a precise estimate for screening? Can we bring in more doctors with a range of money, especially like when PMJY tried to do this in the context of stents, bringing in bare metal versus drug-eluting stents. There are some lessons there that can easily come into this context as well, I feel. Dr. Raja.
It was very interesting to hear what Mr. Tulsi mentioned, and then it has started some debate on that. The cost
you want to move on?
Care. So it's about like when you have this. Am I audible? Sorry.
Yeah. Go ahead.
Yes, you are.
So with regard to what Mr. Aris mentioned about anti-VEGF injections, they are specific to, let's say, diabetic macular edema treatment. When we say that we want to increase affordability, and let us say Ayushman Bharat or some other project covers anti-VEGF injections, it still does not mean that everything is going to be all right and patients are going to come to us for all the care that is required, because the cost of access to care is not just, as was already mentioned, the patient, let's say traveling, but also opportunity cost. So if a patient is employed, is working somewhere, he has to take a day off and still come. And also for someone who is accompanying the patient. So what we have seen is that even in the developed world, where they have care either by public funding or even private insurance, let's say the US diabetic macular edema treatment, let us say under Medicare. Even there, the Medicare data shows that as per the DME protocols for treatment, the number of injections which are recommended are 8 to 9 injections per year. But there, the real world data shows that the average is hardly 4 injections. So if you try to remove one hurdle, you will still have many more hurdles which we are not seeing now or not focusing right now. But again, it's okay that yes, we need to solve the bigger problems, but then we will have to face the smaller problems. But that's a very important point which was brought up, and that's where when you solve price affordability just by the perspective of the pricing of a drug or a procedure, you need to go much more beyond that. So because the access is, let's say, going up to the doorstep, and there you will realize what are the other challenges for the patient. So you need to work on all fronts to get access to all kinds of patients.
Okay. I just wanted to remind ourselves that guidelines. Okay, maybe take other questions here before I go and remind ourselves. Other points, other thoughts here in terms of screening and how to settle the guide. I think this is a very much a political economy question, to be honest about it. At one end, we have this issue of nailing through cost effectiveness studies what should be the menu for diabetes screening and estimating the effects of that on outcomes and care. But in addition, it's also about bringing, as you rightly said, Dr. Raj, and many others said as well, bringing the stakeholders on board while not compromising on quality of care. So obviously that tells you that there's a political economy aspect of healthcare here that will immediately get switched on while you try to implement this. Other thoughts, Dr. Murthy, Claire, anyone else wants to contribute, or broadly, maybe I can give it over to the next panel, Arnaz?
Yes, Chirantan, if you're done.
Okay, thank you.
Thank you.
Thank you all. I think we'll move on, in the interest of time, we'll move on to the next panel. And this is our last panel discussion. And I would like to invite Dr. Padmaja from LV Prasad to moderate the next session, which will have Dr. Claire Gilbert and Mr. Tulsi Raj.
Good evening, Claire and Dr. Tulsi Das. And I think it was pleasure and always inspiring to say Claire and Tulsi both in one frame for me. And and I'm possibly we should meet physically soon. So as you see that in this whole program, when it comes to guidelines and operational guidelines and screening guidelines, I'm sure, Claire, we had an extensive work that done by PHFA, and we were all partners in that whole effort. So, and then whenever we did these programs, right from whatever this 15, 16 years in my small journey also, we have been involved in many of these guidelines and documents being held, and then many programs also run on a successful mode in a project mode. So, but a country like India, what would you think, how we can this actually take this forward? So based on your experience, and you have been on foot completely involved in this program. So how we can take this forward? And also, again, coming to the question of outcomes. So this program, the goal was written better patient outcomes. So whenever we talk about screening programs, so we say screening program outcomes and then patient outcomes. So do we also need to define patient outcomes when we design this kind of a program so that there is a engagement of the patients in accessing the care?
Thank you very much, Padmaja. And I'd just like to thank the IHOPE for inviting me to be part of this panel and some very, very interesting presentations and fascinating discussion. So I would just like to start with the program outcomes and the screening outcomes as they're related, obviously. And I think what is a very interesting place to start is to do a theory of change for any program, or sometimes known as a logic model. So you start with a goal, and then you work backwards to the outcomes, and then the things that need to be in place, the outputs to achieve those outcomes, and then you come to the inputs. And that then allows you to see where the possible blocks are along the way, the challenges and the bottlenecks, and the assumptions and as well that you might be making. But it also allows you to see very easily and clearly which are the key things that you want to be monitoring in a program. So if we take a goal of a program for diabetic eye disease, would be less visual impairment from as a result of the program. Now, often the goals of programs are incredibly difficult to assess because you need to have baseline data, preferably population-based, and then after the program had been running several years, you'd go back to the population to see whether there had been a change in the incidence of blindness or the prevalence of visual impairment. Really, really challenging things to do. So often one has to stop at the outcome level. And this is where I think you raise a very interesting point, because we tend to very much focus on visual acuity as an outcome, which is fine. You know, it's quick, it's easy, it's relatively reproducible. But certainly in other parts of the world, or many parts of the world now, they're focusing more on patient-related outcomes, certainly in clinical trials. So someone with ARMD may not care whether they can see 2 more letters on the line after treatment than before, but they may care a lot if they are better able to recognize people across the road because the area of edema has shrunk, say. And so working with affected patient groups to come up with outcomes that are meaningful to them, often in terms of functionality or quality of life, can add another whole basket of interesting outcomes, which are of importance to the population being served. That would probably require some research to come up with that, qualitative testing, some of the tools that have been developed in other countries. So that could be a sort of an outcome level for programs. In terms of screening out indicators, one of the big challenges that we faced in the Trust program was knowing what the denominator was, because we had a goal of screening 50% of known people who are known to be diabetes by the end of year 2, increasing to 75% by the end of year 3, but without knowing how many known patients with diabetes there were receiving care in a particular district, we had no idea what proportion of the need we were addressing. And it has to be said that the NCD program was not that mature when we started, and hopefully their data systems are improving, maybe in some areas better than others, but actually knowing which is the population to screen can be a challenge. And that's why starting in places where people with diabetes go voluntarily to receive care, be it for their medication in pharmacies or in clinics for people with diabetes or hypertension. That's why we started in those facilities, because that's where you had a captive audience. So going forward, gosh, this is a really very, very big question. And I just wanted to say to Casey that I'm waiting with bated breath to hear what the outcome of his exploration of all these different models, bearing in mind sustainability. And it has to be said, what's acceptable to patients. Because if patients turn up, they have an image of the eye, they've spent their time to be told the eye is normal, they may not come back again because they don't see it as a good use of their time. But if some other services, such as presbyopic correction, could easily, quickly, and inexpensively be added to that, then that will have a more satisfied customer, as well as being able to generate some income. So I think there's been a lot of extremely interesting and important work that's been done in India, which needs to be really rigorously evaluated using all the tools and techniques of intervention science, which is a fairly new approach to public health research. I think in eye care, we're way behind the field compared to other areas. And this may involve cluster randomized trials or a whole range of different types of study designs. So when you have a model that you think works, how can you really rigorously evaluate it to make sure that it is robust and working well, not only in one context, but is it applicable to other contexts, or does it need to be changed? So these are the kinds of questions that you can ask when you're doing an intervention science type evaluation. So I think I'll stop there.
I think, thank you. I think, Mr. Tulsi, please let me know, sir, your views on the same subject, like how like Claire, actually almost it was like a textbook for me, how actually we can actually design the studies based on the outcomes and everything. So if the patient is sometimes, now I can say that this today, the meeting, we are having almost all segments. Sometimes is it important that, the patients, also patient engage, also there is a engagement is there. So how patient factors should be taken into consideration when we actually design these programs?
Yeah, so maybe one approach to this may be to kind of recognize what the challenges are. And I think there are quite a number on the patient front, and then equally on the provider front as well. And then we can, I can share some thoughts on what can mitigate some of them. Like for instance, in India, still about half the persons with diabetes are yet to be diagnosed. And then the saving grace is that in the early stages, it doesn't seem to affect different body parts and create this thing. So what really happens is when we discover diabetes, it is normally around some issue, and it's quite often a sequelae to diabetes, which means the time you kind of lost some time, to work on prevention and and then to get to it. So I think that's one big challenge. And the second is around the place of diagnosis. In most places, the discovery of diabetes in a person happens in non-ophthalmic settings. In primary care centers or in physician's office, or the few who go for annual health checkup. That's where it is often picked up, but they are very few in number. And then today, we don't have a mandated process or a protocol to ensure that this person would get an ophthalmic examination. So even after discovery, there isn't a clear guidance. So that's a challenge. And then the third challenge is it's changing now quite rapidly, but it's still the norm is that the diabetic retinopathy is diagnosed by a retina specialist. And we know there are very few in number, and then this is where the access issue comes in. And the flip side is, if there's 75 million people with diabetes, that's the current estimate by IDF. Now, if they all show up for their annual exam, I think all the ophthalmologists in the country, if they just dealt with that one examination, won't be able to complete it. So these are all kind of challenges. And then I think this is what has led to patient behavior. And we kind of accuse the patient, but this is the reality. That since there is no vision loss, so any early referral to ophthalmologist, they're less inclined to go to the ophthalmologist. And then it is further, the reality is that less than 1 in 10 may require active monitoring, and then possibly 1 in 20 may require active intervention. This is if you take all the diabetics, if they were able to show up. And I think what is possibly changeable is provider behavior, which today does not really own the patient's ocular health. Your general. So that's the point that Casey also was making. I mean, they don't want to make the investment in technology or equipment, which can help to screen for diabetic retinopathy. And then even the ophthalmologists who are monitoring diabetic patients do not want the compliance by the patient. It is left to the patient. If they come, they come. If they don't come, bad luck. So, and very few monitor compliance. So all these issues are there as challenges. And then very briefly, I think some of the solutions that we can look at is, one, for being pragmatic, the eye care providers can probably limit the focus to known diabetics, known who are already diagnosed. and then figure out a way of conducting diabetic retinopathy screening or even more definitive diagnosis at the first point of contact, wherever that may be. No, I think this is going to be an uphill task, but I think the solution or will make progress only when that happens. And this would require integration with primary care providers. And today it is possible, certainly in India, because NCDs are part of primary healthcare now. And I think we have to much more aggressively harness technologies, both for imaging, low-cost imaging, as well as AI-based interpretation. And then I think in order to address this whole access issue, we have to do something to drive screening, diagnosis, and routine monitoring to local levels of care. And then limiting referrals only to those who need active intervention or monitoring. Yeah. And finally, the point that Claire raised, we need to figure out denominator-based monitoring. Because today we really don't know. We really, we keep quoting numbers in millions, for advocacy or whatever. But to do the work well operationally, you need to have much more granular monitoring. We really need to know which patient is not coming for follow-up or being missed out. So we need to get to that level of granularity, and that's something which I think we have lots of work to do, basically.
I think here I want to put one question. So when we say access to the screening and treatment, I think the first step is the screening. So if we say there is also government initiatives, we heard everything. So do you think a fundus photograph at the primary center and at the initial contact point, wherever maybe the diabetic patient contact point, instead of a guideline, will it be like a BCG vaccination or COVID vaccination now? I think that is much more hot topic now. So can that be a vaccination drive, that a fundus photograph for a diabetic patient is a must? And as you said, along with the technology integration like AI interpretation and along with a skilled person who's taking fundus photograph also, because that is also as good as more important than, because otherwise no model will work and they will say again to refer to the next level of ophthalmic care. So do you think a kind of initiative at the government level as well as this thing, it should be something like a mandatory thing rather than a guideline? Because otherwise these guidelines are going on and they're only getting revised and revised. So I want answer from both of you.
Yeah, I would totally agree. I think, but then it's got to be done in a responsible way. Once you mandate, you got to provide the technology, you got to provide the training, and then you also have to have in place the right kind of monitoring to make sure it's being followed. Now, all of that have to fall in place. And I think one thing we need to remember is this animal diabetic retinopathy is a chronic care. It is not like a one-time care. Yeah. So we need to also have that mechanism in place, like a registry or something like that, wherein you are systematically required to do this screening, not just on the first visit, but probably every year or whatever is the protocol that we finally agree upon and put in place. I think if this thing, and plus a mechanism to review and ask questions, it can happen, because today I know it happens for infant mortality rate. When a child dies or when a mother dies in pregnancy, I think the health workers are really taken to task, because they're very good monitoring of that. So it is possible, and I think that's probably the way it can be done. Yeah.
Claire.
Yes, I mean, I would see that would be an ideal to aim for, but the whole backup support system has to be in place, including facilities for treatment, because if the patient's got treatable disease at that first image, then they have to be able to, there has to be that care all the way through the system. So until that's in place, I think it would be premature. So more work needs to be done basically to improve the capacities of secondary level to manage less complicated cases, and the tertiary level for the more complex vitreoretinal surgery and so on. And once that's in place, then one could think about pushing down and really getting some kind of mandated first exam. But I completely agree with Torsi. It's the follow-up. And I'm trying to remember if GV is still on the line. In the trust program, not all the places for screening have been screening long enough to get good data on the proportion of patients who were coming back for annual exam. GV, can you remember what it was?
He's not there. He's
left.
Leave.
Okay,
yes.
Fine. But there was a big drop-off.
Huge drop-off.
First and subsequent screening. Now in the UK, I know we're a completely different population, much better educated. Most people have got cars or access to transport. It's much easier to get an annual screen. The proportion who are seen regularly is in the high 80s every year. It's taken a long time to get there, but it is possible if you've got all the right nuts and bolts in place and it's adequately resourced. So it's political priority as much as anything.
Yes, thank you. Dr. Kim?
I just wanted to add, what you were mentioning about screening these patients, like, Dr. Nam has introduced in the PHCs, like, patients come to collect their medicines. So the PHC medical officer ensures that every patient, our team goes there to screen these patients for diabetic retinopathy. So only after they get their eye screening done are they even given the medicines. But this is something that's done locally, but this has to be, like when you said, to the whole country, it really has to become like a system. But then again, as Tulsi mentioned, there's no system to monitor whether the patients take the next steps. So those are a few challenges that are there. And then even in places where you screen them, you identify them, do we have the system to follow these patients? Like to give that care for diabetic retinopathy, is it there? So those are things that the implementation team should take into consideration.
Thank you. I think we had a very nice discussion on defining how we can define even not just only screening outcome, but what should be the patient outcomes based on theory of change, keep a goal and then coming backwards, and also defining what should be the access to the screening, how it should be integrated with an integrated primary healthcare system, and also the access to the challenges, not just only for the screening, but also for the treatment, and also importance of having actually a complete capacity building, which is going on at the backwards, so that we can actually mandate that, yes, any patient diagnosed with diabetes will undergo diabetic retinopathy screening as a mandatory measure. Thank you so much. And Raja, key takeaways.
Thank you, Padmaja. Over to you, Arnas.
Yeah, thank you all. I would now like to request Dr. Anthony Vipandas, who is also the co-investigator at IHOPE, to please give the vote of thanks.
Thank you so much, Arnas. Thank you and good evening, everyone. Thank you for joining us today for a wonderful session on access to diabetes care. On behalf of IHOPE, I would like to basically thank Dr. Sudha Chandrasekhar from the National Health Authority, and also for sharing the roadmap of the insurance and the vision of the government of India with us also this evening. We basically would like to also thank Dr. Sanjay Kalra from the South Asian Federation of Endocrine Societies for joining us this evening. Thank you, Dr. Kim, for moderating the panel on improving screening and diagnosis of diabetic retinopathy, and also our panelists, Dr. Banshi Sabu from the Research Society for the Study of Diabetes in India, Dr. GVS Murthy from the Indian Institute of Public Health, Hyderabad, Dr. Nilesh Shah from Metropolis Healthcare, and Mr. K. Chandrasekhar from Fortis Health. Thank you once again for joining us this evening. And also thank you Professor Chirantan for moderating the panel on addressing affordability of diabetes care services. And also our panelists, Mr. Denny John from PharmaQuant and Mr. Aris Rizvi from AON. Thank you very much for joining us this evening. And finally, thank you very much, Dr. Padmaja, for moderating the session along with our panelists, Dr. Claire Gilbert from the London School of Hygiene and Tropical Medicine, and Mr. Tulsi Raj Ravila from the Arvind Eye Care System. I'm sure this evening, bringing all of the different stakeholders and different minds, we've had the opportunity to discuss and share experiences and also look at how do we move forward on all fronts, for the betterment of care for our patients. So on behalf of IHOPE, we would like to thank you all for joining this evening. And once again, for all of our speakers and panelists, thank you once again for joining us. Thank you. Have a good evening.
Thank you, everyone.